Titled Navigating Mental Health Challenges in Paramedicine Education, Ensuring Support and Resilience During Clinical Rotations, presented by Dr. Ryan Batenhorst. I'm going to pass it over now to our presenter. Thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Hello, everyone. Thank you very much. As Rio said, my name is Dr. Ryan Batenhorst. I serve as an assistant professor in the Department of Paramedicine at Creighton University in Omaha, Nebraska. I'm really excited about this presentation today because what I've gathered this data from is from kind of another spin from my dissertation for my terminal degree, which was exploring whether or not childhood trauma had an effect on the potential for students to have post-traumatic stress symptomology in paramedic education. So as everyone who does any sort of research knows, all good hypotheses can be ruined by data, as was exactly the point with this, or the result. So, however, that said, there was some very interesting data that did emerge from this study, and this is what this is about, to share that data. So, with that being said, we'll talk about kind of what we're going to talk about today is some psychological challenges faced by paramedicine students during clinical rotations specifically. We'll also explore the ethical implications and potential mental injury in paramedic education that can occur. Discuss some proactive measures and support systems to mitigate stress and foster resilience for students. And then finally, explore the role of educational institutions in promoting a healthy learning environment, which I think as educators, we all are striving to achieve. So the background on this, and all of you that are paramedics or EMTs or EMS people at all, and educators know that paramedics experience high risk situations involving multiple sustained trauma and high levels of occupational stress. We all know this stuff, or we thought we did. Paramedicine students are also exposed to the same pain and suffering that paramedics are. That said, they may or may not be prepared for those same stressors. The significance of this also is that with the educational standards right now, they're placing more emphasis on stress management. In the whole world of first responders, military, everything, there's a lot more focus being put on mental health and resilience and suicide prevention. And with the ed standards, they'd also suggested to be including at a complex or comprehensive level. That said, that's not easy. All of our curriculums are jam-packed full of information, and adding some more, sometimes what people classify as touchy-feely stuff to the curriculum makes it a lot more challenging with both buy-in from your constituents and your students, along with even sometimes your faculty. So the aim of this study was to integrate the findings to incorporate a trauma-informed education that encompasses post-traumatic stress symptomology, but also maybe coping mechanisms, grounding exercises, all kinds of things that we can help our students become more focused on well-being paramedics, if you will. We're trying to help them prepare and navigate the demands of the critical incident exposures that will occur in their future careers, and have that be a focus of our curriculums that right now I feel sometimes is kind of missing. So the research focused a little bit more on some of the students, and if you look at some of these dates, this is pretty old data, but paramedicine students may be at higher risk of developing a post-traumatic stress injury due to age, inexperience, and the added pressure of academic evaluation. Guys, I don't think sometimes we pay attention to that. I don't think we quite wrap our heads around the added pressure of being a student along with being in these clinical rotations and everything else that's going on in their life. There's data to support, and I think hypotheses gathered by a lot of us thinking that these students today are less resilient than perhaps before. So we got to think about that in paramedic education as to how do we address this. Paramedics are just as likely as paramedic students are just as likely to, as paramedics, to experience trauma exposure during their placements. Probably more likely because their interpretation of trauma may or may not be different. And we kind of looked at factors such as proximity. Are they the team leader, or are they just or are they just observing? How many of these calls did they go on? Did they feel like their life was threatened on the call? And all of those things made it more likely to predict the likelihood of post-traumatic stress symptomology. If you'll notice, throughout this presentation, I address post-traumatic stress, PTSI, PTSS. I don't use PTSD as we all usually know of this, because that is part of the stigma that goes along with this. People have post-traumatic stress symptoms as a result of a traumatic event, and it all of a sudden becomes a mental illness or a disorder rather than an injury. If you injure your back or anything else, you rehab and you come back to work. If you injure your mind from a traumatic event, now you're labeled with a disorder. And I think that's part of changing the foundational stigma of this. So in my study, the participants in the setting, it was a purposeful sampling strategy. So I sent out a survey, which in my survey was the ACEs scores as well, but we found that to be a non-correlation to symptoms. However, so my N was 81, so I had 81 people respond to my survey. And the inclusion criteria was pretty simple. It was students enrolled in the paramedic core coursework, and they had to complete at least one clinical rotation, just one. And the programs that I surveyed were in the states of Iowa, Pennsylvania, Virginia, Texas, and Oklahoma. So kind of a wide base of people throughout the US, and paramedic students in lots of different programs, whether it's a community college setting, a university setting, or a consortium or satellite program setting. So here are some of the questions that I asked. Have you ever had a stressful or disturbing experience that occurred while attending a clinical rotation, either in the hospital or in the field? That's typically a yes or no. That clued us in. Can you describe that experience, or what was stressful about it? Have you personally had ongoing continuing health-related symptoms as a result of that experience? And can you describe those feelings? And then finally, how did you cope? Many of us that have been in this profession a long time can describe coping strategies that may or may not be exactly what we would consider healthy, me being included. So it was interesting to hear how students cope today. Here's what my study did reveal. Almost half, specifically 48% of the surveyed paramedic students reported having symptoms of post-traumatic stress after they participated in a clinical rotation. 48%. So I'll tell you, when I first got the results of my survey, I was disappointed that there was no correlation between childhood trauma, but my statistician working with me is like, man, you got to look at this instead. This is incredible. 48%, folks. 48% of our students are suffering mental injuries as a result of our curriculum. So this was alarming to me. I don't know if it's alarming to you, but to me, it was incredibly alarming. Some of the symptoms, and I'll talk about a little bit more here shortly, but depression, anxiety, panic attacks, shortness of breath, anger, crying, social anxiety. And guys, the other thing that was interesting to me is the students that I've experienced that have had these symptoms as a result of clinical rotations come back to us saying, I don't know what's wrong with me. They don't understand that these symptoms are a result of that traumatic event. They all of a sudden have these post-traumatic stress symptoms, and they can't correlate that. They don't understand that that's what that's coming from. So it's an interesting thing to tell them, well, this is a normal response to trauma, and these are things that happen as a result of those experiences. And they looked at me like, oh my gosh. And then the even more unnerving question was, so am I going to be labeled with a post-traumatic stress disorder? Am I now a psych patient? Knowing how and seeing how sometimes we don't necessarily always treat psych patients with the respect that perhaps we should. So this really got in the weeds with me. I was pretty profoundly blown away, if you will, by what the students are saying and the data that emerged from this research. So this study ended up being a mixed methods study. So the qualitative themes of this that emerged were the ones here on the screen that I'll talk about. And the quantitative ones were from the ACEs scores that have been taken out of this study as we emerge forward. But the first theme was stressful and disturbing experiences. The second theme that emerged was post-traumatic symptoms they experienced. And then the last one were what their coping strategies were. They talked about those, obviously, as a result of the questions asked. That said, some of the responses that we're going to talk about in the slides coming forward could be triggering. So just, I want you to be warned about that and to be mindful. So these are the stressful and disturbing experiences that emerge. So traumatic and disturbing deaths, high stress situations in life and death. I'm skipping to the last one, impact on personal well-being and emotional resilience. But the one that I have highlighted and in italics is challenging interaction and professional conflicts. Another interesting thing that emerged from the research that, there's a lot more emphasis on interdisciplinary education with working with other disciplines in simulation or anything. And the data that's emerged from these surveys are students are struggling working with other professions, which is interesting that they classify as stressful and disturbing. So not only is examining these experiences critical, but perhaps from an interdisciplinary approach. So these are, in quotations, some of the things that were pulled out of the data that were verbatim what they said. So, patient stabbed 27 times, motorcycle hit by a semi, infant code with SIDS, suicide of a young person. You can read the rest. But the point of this to me is that we all know the age of our students. Some of these students that are experiencing these situations are 18 years old or even younger, perhaps. But most are in their 20s. Now, we've all had exceptions, I'm sure. I most certainly had. I've had paramedic students in their 60s. However, no one is prepared, especially an 18-year-old, to see these sort of things without any preparation. And I think this is something that has emerged that we have to consider. Post-traumatic symptoms that they experience, so depression, outbursts, more irritable, nausea, crying, loss of motivation, trouble sleeping, anger, continuously seeing the patients, frequent and longer panic attacks, social anxiety. Now, if you're a paramedic or an EMT or any EMS provider or a first responder or anyone, these are perhaps the same experiences that you've had, that maybe if you've done this for a long time, we're told that, well, welcome, this is part of the job. You got to figure that out and find a place to put it, but you can't let it affect you. Unbelievable, something to consider. So clearly in the coping strategies, that same advice has made it to new students. So what are their strategies? I spoke with my therapist. I talked with my family and friends. I talked to my wife. I've sort of threw these on one side of perhaps on the left being healthy, in the middle, and on the right, maybe not so healthy. But guys, I want you to think about this. If you've done this for a long time, were you given some of this, I don't know, people have given you pointers on how to go through paramedic school and went with, I just have to push the thoughts and feelings to the side. The work in healthcare, it comes with the job. I work. I didn't have time to sit and cope with those feelings. I just kept it to myself. These are the things that our students are hearing as being part of the job, that they're signing up to be mentally injured. And well, that's what you signed up for. How do we look at that? So with this, there's some proposed solutions and implications that I've outlined going forward, and some things that we're trying at our university to meet our students and talk to them about what is it that we can do to be more helpful and to find strategies to work with them. So in our curriculum, this is another thing that I want to challenge you. So with regard to curriculum, I talked about in the beginning that, you know, our curriculums are jam-packed, and most of us are trying to get it done in a 1 year or 2 years. Most programs, now some do, I know, um, some do, and some are 4-year programs that have time to look at this and time to work in this and add to their curriculum. But guys, I want to ask you this. There's several studies that have reported that replacing a portion of clinical retirements with simulation is equal to, or in some cases, more effective than equivalent clinical experiences. Think about if we replaced clinical rotations with simulation. Now I can hear you in my mind yelling at your screens right now, going, "This guy is crazy. We can't. How will they get those experiences?" Well, I also want you to think about, as an educator, thinking about Bloom's taxonomy with regard to what are we looking at with cognitive things in the beginning. So the lectures and the exams and the assessments of all of that. So low level learning, if you will, recall, knowledge. We start to move to the lab where we're starting to move things forward. We're starting to apply those skills and that knowledge that we've learned. But yet then we go to the clinical piece, which is typically the last part, or even the high level application synthesis level learning, where we're talking about putting them in a team leader role. And what is the process for you and your program? I know our programs that I'm familiar with, most students go out there and go to the ER, do ride time, go to the OR, and we tell them, best of luck. You're going to go follow a preceptor that's maybe not a paramedic, but is a nurse in the ER to do a job that's typically not what you're going to do if you're looking at pre-hospital medicine, from a person that's not an educator. And we're expecting to kind of put the roof on their learning with clinical education. What if simulation was used in the early part of clinical education, where we could measure it higher and be there and be corrective and have a more intentional, measurable, high level learning curriculum and have higher level outcomes? Again, it's a paradigm shift in our education, but think about how we could add the mental health, the wellness, the well-being element into those clinical rotations that are even in the beginning, to where, you know, we can simulate things like death notification, injured, sick, and dying children, and then have a mental health element to that too, and to talk about that, so that these students aren't experiencing this for the first time for real, with a paramedic who's probably potentially, not always, a seasoned veteran that's telling them to, you know, this is part of the job, man. You got to just kind of suck it up and move on. And they don't know how to do that. So something to consider. Now, is that popular? I don't know. It depends on how forward thinking you are and outside the box you are. It's not way out of line, even from an accreditation perspective. It's more than welcome to add simulation. And with clinical education being harder and harder to come by in certain places, it may be a very viable option to consider. Again, just something to put in your brain to think about. That's the whole intention of this presentation today. So I want you to think about this, the way patterns of stress emerge within our lives and in our brains is sensitization and tolerance. So when you think about patterns of stress, unpredictable, extreme, and prolonged stress is the most common forms of creating a vulnerable person. Tolerance, which is predictable, moderate, and controllable stress, equals resilience, or is more likely to result in resilience. This is a lot of the reason why the studies that have emerged with people that have been prisoners of war are less traumatized than people that are out on the battlefield. And it's because of absolutely this, that trauma is predictable. Every day they're tortured, which is a crazy thing to consider. But if you can wrap your mind around things that are predictable, even if they're horrible and controllable, where if it's unpredictable and you're surprised by it, which, ladies and gentlemen, as you know, is the foundation of pre-hospital medicine and medicine as a whole. So I'm not saying we can make it, our profession predictable, but how can we prepare students to be able to manage unpredictable with more of a predictable means by being prepared, et cetera, et cetera. That's a whole another conversation. So implementing trauma-informed education simulation and support programs. So guys, I'm going to make this sound like this is an awesome idea, and it is. In my heart of hearts and my brain, I'm all for this, and I have implemented it at our university. But buy-in is hard, and it's really hard if you're focusing on changing the world of paramedicine from a full. Not going to go out to the fire station and start trauma-informed education. Now, some people are going to be open to it, some are not. In school, if we change the world of paramedicine and as well create a paradigm shift in our profession, we have to with students and the people that are emerging. If we make it normal to have conversations about well-being and wellness and mental injuries, that will continue to move on in our profession, which will ultimately end up changing. So look at peer support networks. Students, I always, when we first start our program, we talk about within your program, you need to identify a critical friend or critical colleague. It doesn't necessarily need to be another student, but it needs to be someone even on the outside that you can confide in or you can talk to about things that you're experiencing and what you're struggling with. Maybe not even as a result of clinical rotations, but how are you managing your course load? How are you managing your life? Are you able to work enough to pay your bills? Mental health resources is another thing. As you're starting to look at how do we change this curriculum, mental health professionals need to be part of that discussion. What is the options available for students if we need to take the next step and move towards a more definitive mental health care? And I'm grateful in our institution, we have a whole mental health department that came and walked with us in this journey of trying to create a better, more well-rounded, mentally well-being student, if you will, focus. Faculty training. How do you meet with your faculty to discuss moving forward with this proposal? I mean, people, I hate to say it, have been doing this for a while, and not everyone's all about touchy-feely. Not everyone thinks this is paramedicine's getting soft, the world's getting soft. Or is it we're just a new generation of people that are acknowledging the fact that, hey, this is an odd way to do this, that we just go out there and sign up to do a job that's 24 hours at a time, that we don't get paid what we think we're worth, and then we leave with post-traumatic stress. I mean, what an infomercial that's going to make people sign up. So something to consider. How do we start to shift this paradigm? So implement a comprehensive coping strategies. What are some offerings that we can do? How do we offer psychoeducation sessions? Can we bring in those mental health people and talk about coping strategies? Even to have stress management workshops. It's all over the place that people think that the younger generation is not able to manage stress. That's not true. They can manage stress. They just do it differently. So we look at things differently. And now we're at a different generation. As many of you know, if you're a Generation Xer or younger, or even a baby boomer, dealing with the generation older than you was always difficult. I remember now that the Xers are the people that are judging. When I was young, my baby boomer father we didn't even speak the same language from my perspective. So it's not really that different. It's just a different focus because it's different than what we think. So promoting self-care practices and workshops, if you start talking about, how as a student, have you tried meditation? And your faculty member looks at you like, are you kidding me? What are you talking about? Well, that's going to create a buy-in issue with your students. You have to work with this faculty and have these kind of things thought up before we move forward. That said, then you have to promote that self-care for education for faculty as well. The faculty need to be part of this and need to have some buy-in. They don't have to necessarily agree with everything at first, but have them work through it with you. And if you're the champion of this, moving this into your program, what is it that we can do that we can work together as a team and find that happy medium in there? So next, I just kind of want to discuss what we did at my university. So we decided first to implement a discussion/support group. We kind of put it out there first as a discussion group, like, hey, let's meet after my class, and we'll talk about stuff. It doesn't have, if you start talking about, well, we're going to create a support group. Well, that feels mental healthy and mental stuff, and that now we're pushing that stigma button. So you have to kind of sell it a little bit. So go meet with your mental health people, your counselors. What is it where's my line, first of all, as a paramedic educator, that if I have a student that is struggling, where is it that we need to go further and get them some more focused mental health care? We also need to decide what is it that we want to do with this discussion group. So creating a clear purpose and objectives, training the facilitators or having education and wellness, things like that. It's also very important to talk about confidentiality and safety guidelines. This is a safe space. What happens or what is talked about in here has to stay in here. Even if you have them sign forms that says that, something to create a sort of a pseudo fence around the room that, hey, this is a safe spot. Have a structured format, have a start time and an end time, and, create an environment that's friendly and open. Have it be the same time, have there be a schedule that's really there. Resources and materials are things that you can also work with your mental health people. What resources are available to you if you have a student that tells you that, they're really struggling and considering further means of harming themselves? What are your options? Which goes right into a referral system that needs to be in place before you start this, because I will tell you from my experience, things will emerge quickly in some of these environments. So a feedback and evaluation mechanism. Ask them, what do you think? How's it going? How do you feel? Do you feel like this is too intrusive? If so, how can it not be? It's their group. Use them to help you understand where they want to take it. And it doesn't have to be about, oh my gosh, I had this terrible clinical experience. It could be about, I'm having trouble managing my course load. I don't understand cardiology. Who can I talk to? And that safe space, so that the students that maybe aren't really bought into it because they think it's too much, this is a place that, hey, this isn't all about, sitting around singing Kumbaya, as you can imagine is being said. It's more of like, these are people that are there to help me be successful and that are interested in my ultimate success. Where I promise you, students always don't think that about faculty, that we're there to help them be successful, whether we are or not. So here's the name of our group, which we're still working on, to not be too corny, but Resilience Response. It's kind of a dual meaning, and it's really a supportive community for wellness and growth. And that's how I advertise it to our students. This isn't about sitting around. This isn't a critical incident stress debrief team. This is a group of like-minded people that are here to support each other, be successful. And that's what it's about. So I created a purpose statement. So the purpose of this group is to provide a supportive, confidential environment for paramedic students to openly discuss and process the challenges of well-being stressors associated with their clinical education, student responsibilities, and personal lives. So it's not all about clinical here. It's about all of it, with an option or a pathway to get them more help if needed. And through peer support, some of these students are sitting next to people that are going through the same exact thing they are and don't know it. So this is a great place to have those introductions happen and those people to identify those critical friends. Some people, when you ask them, I need you to identify a critical friend to help you through this process, they look at you like, I don't know what you're talking about. I don't have critical friends, especially in this world. And this, we keep bringing this back to a generational thing, which isn't necessarily the case. But a lot of the relationships in the younger communities are through technology. So they don't always know what a critical friend that you can come to and talk to about really deep things. So, we'll focus on things like reducing isolation, building resilience, and foster strategies to manage the stress and the symptoms, and to identify and tell them that is what's happening when they're not sure. But also to talk about strategies for coping, like grounding exercise, meditation, wellness, exercise, all of those things. And, some of the forces and shortcomings behind numbing and things like that. So the objectives of the group and goals are really to provide a peer support system. It doesn't have to be group therapy. That's not the focus, nor do I have the licensure to do so. And I tell them that from the beginning. This is not a therapy session. This isn't the opportunity to talk. And if it becomes deeper or you need more than what this group's scope is, then we have the means to do that, which is comforting to people. One of the biggest goals, and that's why I underlined it, is to normalize the mental health challenges that students are experiencing and that pre-hospital people are, or in-hospital people are. Because right now, we don't talk about this. I literally had a faculty member that's a part-time faculty person, that's a retired paramedic, that said, this generation of students needs to figure out how to compartmentalize things and push that stuff down so that they can learn how to deal with this career. I'm mortified. That is exactly what our generation and the generations before us have done. And that's why the people that are struggling typically, or have chosen to end their lives, are typically at the end of their career, not the normal. Not all. And like I said, typically not all. So we want to help them develop resilience. And what does that mean? It's a big buzzword today. What is resilience? Everyone's resilient, grit, all of those fancy words. Well, let's talk about what it means to be resilient. That doesn't mean you're not going to go through stuff in your life, but it means how are you going to grow from it, and not deal with it, but grow from it. And what are some coping skills? We want to promote, again, those access to resources. And guys, I don't mean to keep bringing that up, but that's really the focus of this group, is to, even create a foundational avenue to where we can identify students that are struggling before they are. I've talked to program directors throughout the nation that have had students commit suicide. That's a terrifying thing to wrap my head around, how that happens and what we could do as educators to prevent that. And I think this is a perfect way to at least start the conversation. We want to enhance professional preparedness, because at the end of the day, what are we doing? We're building paramedics. These people are going to go out and come out and take care of our own family and friends. And we want them to be prepared both educationally, but also mentally and psychologically. And then lastly, build a supportive community that isn't just here for school. I mean, many of you that went through paramedic school or EMT school or anything, medical school, nursing school, have people that you've known for 30 years that you met in those educational settings. This is a really great place to begin those relationships. Now, as any good educator, outcome assessment options. So you want to measure whether it's working. I mean, you can do informal assessments all day long and ask them, what do you think? How do you feel about this? What are your suggestions? Give them some ownership in what we're talking about. ask them, what should we talk about next time? What's a good icebreaker to bring to get people here? Where can I find champions in the first group of people that show up to snowball out there and bring more people in? You can track attendance. Give them surveys about, hey, how do you think? Maybe they don't want to talk about it out loud. Maybe they would rather do it in a confidential survey. Ask them how comfortable they are to have these conversations. Guys, and I bring this up once in a while too to my students. It's like I started this process of having a discussion group in a prison setting. I also teach trauma and shame, or facilitate trauma and shame and vulnerability in the prison system. So if I can create a comfortable environment in that arena for people to come forward and talk about things that are hard, that may become dangerous for them if it's out there, I think we have some good strategy to help students also be in that same environment. What are some other surveys that you can come up with? And then when they graduate, put that in there. How did it go? Was this helpful? In our course, we just added a asynchronous course in the capstone portion that's called Transition to Practice, which we talk about these kind of things. What are your strategies? How are you going to manage this thing? How would you walk somebody through a death notification experience, to just have us work through that with them so that we're there for the first time. I don't know about any of you that are on this presentation today, but some of my first experiences in those traumatic situations, like a death notification, was my partner or my preceptor telling me, I don't know, go talk to the family, tell them, hope for the best, plan for the worst. I don't know. That's what I say. That was my first experience at doing a death notification. I don't think that's fair to our students, and I think it's absolutely mentally injuring them to have them do that. So there's plenty of evidence that support this solution that I'm proposing. And this is just one, guys. There's all kinds of other opportunities. This was where I wanted to start with our students. And that's, paramedics are prone to secondary traumatic stress symptom development. So, not only are you stressed from the job, but now your resilience is weakened. And now you have other stresses that are becoming traumatic that normally weren't. Trauma-informed education can help students understand the potential impact of trauma exposure. How many times in your career, if you're were or are a practicing paramedic, did you go into a scene where there was an obvious death or something else, where everyone in the scene went in there to just take a look or whatever? Guys, those are some of the things that stick in your head for years. And how many of those calls can you recall in your head that you didn't need to be there, or you didn't need to go in, and you intentionally traumatize yourself? Well, we're having preceptors subject students to that on purpose to get them ready for the career they're going to explore or enter. Now, some of that is going to happen, I understand. But to intentionally traumatize people without preparation, that's what I mean, is not necessarily that they shouldn't experience those things, but we should walk them through some of that in simulation or something like that first, to give them an understanding of what they're going to expect, and or how they can, moreover, moreover, how they can cope with those situations. Now, I also understand, being an experienced paramedic myself, you can't prepare for every situation. I understand that. But you can help them prepare for how they react to them. So when they start to have symptoms, having them be able to recognize and know when they're more than just, I'm having trouble, sleeping, whether it's I'm starting to have intrusive thoughts and things like that. Those are when we need to start looking at how do we get you help, and have the student be prepared to understand that that's what's happening with them, rather than them panicking that now they've become a psych patient, whatever that means. So a comprehensive post-traumatic stress support program, including screenings, counseling, peer support networks, have been shown to be effective in reducing symptoms and promoting recovery. So again, if we focus on these traumatic events as potential injuries rather than disorder inducing, we change a paradigm and we potentially save our profession. So some of the challenges, of course, there's challenges. There's challenges to everything, but resource constraints. What if none of your faculty are interested, or frankly, neither are you? You know, what sort of resources are available to help your students? Time constraints. When do we have time? I mean, we had a session yesterday and the student's like, I'd really love to stay, but I have clinical. I have to go to clinical. Well, okay, that is perfectly acceptable. That's part of your curriculum, but we'll be here next week. Have it be that they have the opportunity to come in when it's convenient for them. This can't be mandatory. If you make it mandatory, it's like having mandatory fun. It's not going to work. So cultural sensitivity and adaptation. You know, some of us grew up in an area where there wasn't much culture or anything outside of people of the same descent and skin color. How do we understand that? Do we have people within different cultures come and talk to these students and express things or different traditions and even different part of the United States? And people are resistant to change, and some students aren't interested. You know, if you have students that are ex-military, they might be less interested in dealing or talking with you about this. So, and then does it work? Well, you also have to have buy-in from the students. Do they want to be here, or do they feel guilted into coming? So, you know, if they're doubting that this isn't going to work, then maybe it isn't going to, maybe it won't work for them. So then how can we work through that with them? And then, you know, access and equity. How do we provide access for every student? And, you know, guys, as this emerges and continues to grow, how do we involve other health professions? Can you imagine having a room full of medical students, nursing students, PA students, dental students, talking about the different traumatic experiences they've had in clinical rotations and how that could be helpful? I mean, we all know that paramedicine loves to silo ourselves, sorry, and not be interested in other professions because they don't understand what it's like to be out in the ditch working in the snow and the rain. It's still patient care and it's still trauma. Nurses experience some of the same trauma, so do physicians, and sometimes even at a higher level. So what is it that we can work together? Remember that theme back in earlier slides where students are traumatized by trying to work with other professions because they feel like they don't speak the same language. I mean, mortifying to me. How hard is it to work with other disciplines, and how do we do that? How do we facilitate that? So implementation can be a challenge at times, especially if you have people that aren't fully vested in the process or interested even. But, you know, a needs assessment, pretty much the easiest box to check. I think every place, even based on my, you know, N of 81 students, there's thousands of students out there, but statistically significant in the fact that 48% are talking about symptoms they're experiencing. How do we integrate this into the curriculum? Meaning not necessarily having a peer support group or discussion, but rather how do we start talking about, you know, intro to paramedicine? What does intro to paramedicine talk about? Do we talk about mental health? Do we talk, and, you know, my two of the curriculums I've worked with, or 3, 4 in my career, have had mental illness as a patient focus. And what do? You go through all the mental illnesses and talk about, you know, symptoms of all of those, but yet we don't really have an inward focus of what happens if we're experiencing those as clinicians. So most of those curriculums have what, 4, 6, 8 hours of mental health or psych patient education, and how robust is that? Next is faculty training. How do you get the faculty on board to support this and to be champions to move this process forward? Again, screening and assessment, student support. How do we get options for them if there's something that they need more? Peer support networks, and then collaboration with external partners. If we can start creating a relationship for mental health with some of our clinical sites, imagine what sort of a comfortable place that creates for our students. And then ultimately measuring to see the effectiveness and making tweaks and changes of how can we help our students. And then lastly, promote awareness. Look at the students that have had these experiences and through this peer support system have emerged to be successful and are out there practicing and doing big things. So some of the stakeholders are, the leadership. Think about if a student commits suicide in your organization or your institution, what that's going to look like. How does the institution start to look at clinical education then as is this really dangerous, or are we sending our students into something that's maybe mentally injuring to them? We know we are. And it's a pretty easy stakeholder for your institution to get behind. We're trying to protect our students. And education as a business, our customers. How do we protect our students? You have to have faculty buy-in, mental health professionals. You have to meet with them and talk to them about, I am not a licensed medical professional, unless of course you are. I am not. I have an interest in research in post-traumatic stress symptomology for paramedic students and across the board. So I want to know where my line is to get you involved so that they're not threatened that you're, becoming a social worker. Use your student organizations, create an EMS club or something like that for your students to be a part of that shows that the leadership of that club is interested in this. And, we already talked about external partners that will buy in. The factors including are, of course, funding. Money is always an issue. Professional development. What is the updates? How do we keep current on the practices out there and what's out there? Training, policies. How do we have policies to support this and be behind it? So lastly, the implications of the proposed solution, there's tons, guys. Improving student well-being is the foundational focus. Reducing post-traumatic stress symptoms, promoting coping, promoting resilience, cultivating a supportive learning environment, all of these positives. But at the end, and I wrote it twice with once underlying, enhancing patient outcomes. If we have healthy paramedics, both mentally and physically, patient outcomes are going to improve and be better. If you have a person that's completely engaged in taking care of a patient, the outcomes are going to be better. And then ultimately, overall improvement and sustainability of the profession. At what point do we have students saying, you know what? Paramedics don't get paid as much as other health professions. I don't want to work 24 hours. And I've had several of my friends have post-traumatic stress or have killed themselves being a paramedic. I don't want to do this anymore. And all of a sudden, and we're seeing it in the application pools of fire service jobs where years ago there was thousands of applicants. Now there's not even hundreds. So we have to do something and look at this. There's all kinds of implications for future research to contribute to a better understanding of the symptomology, what is more frequent and what happens more. Inform the development of evidence-based interventions. What are some wellness-focused interventions rather than medication or diagnostic interventions? Is there a difference? And then ultimately to inform and support mechanisms to promote student mental health and well-being. So with that said, guys, my last slide. Imagine realizing our curriculums are mentally harming our students and choosing to do little or nothing to change it. Now you know. We can't do anything anymore. We can't sit by and watch our students be injured and ultimately have catastrophic results of these so-called, the way we've always done it, parts of our paramedic programs when we've got data to support that simulation is more effective. Please don't think I'm saying, substitute simulation for clinical education. That's not what I'm saying. but let's have our clinical education be more intentional and more measurable and having a mental element with this. So that said, guys, again, I'm Dr. Ryan Batenhorst from Creighton University, and I would love to try to answer some of your questions if there are some.
Yes, so we have one question here from Roger, sorry. Um, how do you set up student peer support? Students are learning for a year. We don't have time to train classmates. Our school gets wrapped up in terminology. Lab staff are not peers, they're instructors, but peer support trained lab staff can help reduce stress in post-call clinical debriefs.
So, and again, please don't think I'm the resident expert on this because I it's just what I've tried to do and we do at Creighton, and that's creating a discussion group to start it. So we get students together and sit around on a table and just have discussions. It can be about clinical rotations, but it can be more. So, just having that there and have it be outside of class because, and I can feel it. People are like, oh yeah, right. Like they have time to do that. Well, our class, my class that I teach gets over at 4 o'clock on Wednesday afternoons, and we go from 4 to 5 and have our discussion group there. Students schedule their own clinical so they can move it if they need to, but have it be outside of class. Therefore, they don't feel like they're pressured or that it's mandatory, but yet they're already in that room. They have to walk out and walk by you to leave. Not saying that that's pressure, but sometimes it makes them think, my colleagues are staying. Maybe I'll just see what it's about. And that's how it starts. And then you get students that are champions to take it forward out to the other people. So I hope that answered your question.
We have another question from Casey.
Mhm.
Are students included in CISM sessions with the agencies in which they are doing their clinical? Was there any difference in non-credit versus credit students who have more access to university resources? Is the CON chaplain also available to EMS students?
Casey, great question. You're also familiar with our institution. So those are really great questions that are specific. But I do not have students doing CISM sessions with agencies. There's conflicting data to support CISM. And not that I don't see it as valuable, please don't think that at all, because I've been involved in that as well. But I'm not sure that students are ready for that level of trauma discussion because CISM typically, in my experiences, and I could be wrong, these are just mine, it gets pretty in the weeds and pretty graphic. And I just don't know that students are ready at that level to make that be a clinical rotation. That said, maybe at the end, maybe towards transition or capstone, but without preparation, I wouldn't be comfortable with them even observing. Now, there's no difference for credit versus non-credit for us. That was part of my initial pre-work of meeting with mental health to make sure that that was the case, that non-credit students could be involved. And if there was, we had a backup. So we worked with the, oh my gosh, the network for post-traumatic stress for first responders, a first responder network. Oh, clever name. And had another avenue there for non-credit potential students if that wasn't available, but fortunately it is. And then lastly, the College of Nursing, which is where the Department of Paramedicine resides at Creighton University, is in fact the chaplain is available for our students for that, and frequently meets with them and talks to them and gives them opportunities to meet with her. Great questions.
Sari asks, do you provide any education or training for preceptors at your partner agencies who will be with students?
That is a amazing question. So at the moment, no. but at the moment, it's in development. So I would say in our preceptor training, we don't talk about it exhaustively. It's mentioned that mental health is a big part of us and is a big part of our program with regard to mental health, and we want to focus that for our students. So stay tuned that this will be coming, and honestly, the responses have been somewhat surprising. I didn't expect them to be so supportive of that at times because, I mean, we've all been there. You got that guy at the station that's like, oh my gosh, this is ridiculous. I'm not doing this. But the support and the interest has been overwhelming for me. Just one other thing, I saw Casey's comment that he said he was referring to participating in a session if they were on a call. Absolutely, I would invite them to do that. And many have when it's happened and they've been on a call, either as a student or as even if they're doing volunteer stuff on the side. Many have been through CISM deployments and have been out there with their preceptors. And I've had no issues with clinical sites not inviting our students.
Robert says, this is a great topic, and it seems that people run away from mental health talking. I try after every scene to talk about the scene, etc. I also try to talk to the people involved days after. I get answers like, that is what we should get used to, or I am fine. How, in your experience, is the best way to get through that wall of stigma of I don't need to talk? And thank you for a great class.
Hmm. That's a really great question that I've tackled several times in different ways. So man, it's a hot button for me. And when I have people like that say that, a lot of times I say, well, what does okay mean? And what do you mean by we're not doing that? Or why would you choose to not do that? All up to and including me saying, well, if you don't think we need this, why don't you explain that to my 12 friends that have committed suicide and colleagues? Because it is a problem and it is something that we need to examine. Now, I don't say that as just to do shock and awe, but sometimes they haven't had that. They haven't been exposed to that. And we're having students that are going on calls that are experiencing 2 suicides in the same shift. So not only are our students suffering, but the world is suffering. So they're seeing more mental health out there as a student, mental health issues and suicides and things like that. So it's you talk about a pandemic. I mean, it's all over everywhere. So I think that not only are they suffering from it as a student, they're seeing it more as a student. So sorry, that was a little graphic to answer your question, but it's a pretty hot topic for me, if you can imagine.
We have 2 more questions here.
Sure.
Tyler asks, do you have any resources that you would be willing to share with other institutions who would want to begin to build this education into their program?
Oh, absolutely. And I know Tyler, so I'm more than happy to share those with you, or anyone else on this talk. It's always always been my passion. So now that my research that is real and I'm focusing on it rather than just saying I want to do it, and this is what I want to do, and I'm focusing on changing that. There's other ways than just student discussions. There's all kinds of other things to do too, and I'm absolutely more than happy to meet with anyone, talk with anyone, have more Zoom sessions, and do whatever I can to help people develop their own programs. Absolutely.
And Darla asks, have you had issues with clinical agencies bringing it to your attention when students are involved in challenging and high stress calls?
That's funny. That's not funny. That's not what I meant. That's a really great question because I've seen a huge change in that from our clinical partners saying that, well, it's not my problem to watch your students, or not my job to watch your students if they're having trouble, to having, battalion people, captains, shift supervisors contacting us on Friday, Saturday, Sunday nights saying, hey, we just got back from a call that your student was on. And I just want to let you know we're having a team. We've taken them out of service. Your students here. This is Saturday night at 10 o'clock. I mean, so we're having great luck with that. And I think it's part of being just involved in with those people, going out and talking to them and talking to their leadership and saying, hey, I want to know if our students are involved. Because I mean, we can watch your tracking software, if whatever you use to see calls, if they've charted them correctly, but to have your partners give you real-time feedback that, hey, we had a call that your student was involved in, up into including, we just had a call a couple weeks or a week ago where law enforcement had to shoot a dog, and not typically something you would consider as necessarily traumatic, that they would call the educational institution. Now, lots of people would disagree that that's not traumatic, me being one of them. But for them to call me late at night to tell me that, hey, just want to let you know this happened, and we want to give you a heads up about your student was there, which is fantastic, and a huge paradigm shift for education for us.
Right. That one more question actually. Robin wanted to know if it was possible to get a copy of the slide before this slide that is on the screen.
Uh, this one, or whichever one. Yeah, just you have my email right there. Just email me and ask me which slide you want, or the presentation. I'm happy to share it.